This is a podcast about our lived experience, which unfortunately includes infant death and subsequent mental health struggles. Please take good care of yourself and only listen if this content feels safe for you right now. We'll still be here when you're ready.
Hi, I'm Judith.
And I'm Alina. We both lost babies to SIDS in winter 2021.
In the throes of grief, I reached out to a stranger on the internet and our friendship was born.
In the years since, we've been working hard to survive, rebuild, and navigate the continual challenges that have come our way, including divorce,
Job loss,
dating while bereaved,
moving multiple times,
health scares,
pregnancy and parenting a living child,
starting new jobs, and so much more.
We are tired.
Happily ever after is out of the question for us, but this podcast documents our journeys to happier ever after because we believe life after loss is worth living.
So join us as we laugh, cry until we laugh.
Welcome to As Long as I'm Living podcast.
We're so glad you're here. Guys, I've got good news and I've got bad news. The bad news is I think my robot is joining us.
Your robot?
Yeah, I've got this robot.
What?
It takes notes for me. It's like an AI robot.
Hello.
Hi.
Oh my gosh, we can hear you.
So this is on my phone because now my laptop won't work. Is that okay?
It's completely fine.
What difference does it make?
It's completely fine. We will make it work.
You know, you were recommended to us from our online community.
Actually, multiple people recommended you
because we were looking for a medical provider that can speak to being on the medical side of loss.
So why don't we start with
introduce yourself.
Tell us about you. And I will tell you right off the bat that we've been calling you Heather Fluorescent for weeks. Judith has this thing where she cannot say, her brain just confuses letters. She's like, oh, Heather Fluorescent. We have Heather Fluorescent tonight.
But I checked it before I got on the call, Dr. Florescue.
Yeah, you got it perfect. Yeah. But honestly, most people call me Heather.
Okay.
So that's why actually my residency nickname was Flossie. So Dr. Flossie is another one. Yeah, I have several of my residency colleagues who don't ever call me by my name, actually. So just, a little
Flossie
side there. So Flossie works. Yeah. So I always wanted to be a doctor. I thought I was going to be a pediatrician, and then I went to University of Rochester for medical school, and I hated pediatrics. It was just not for me, and I really didn't know what I was going to do with my life. Thankfully, the pediatrics rotation is followed immediately by the obstetrics and gynecology rotation, so I didn't have that quest for what's my life meaning for too long. I very promptly, as a third-year med student, met the first doctor who I ever felt was actually real with their patients. Didn't insist on being calling by their last name, didn't wear a white coat. He, had the earrings and the tattoos, and he said it like it was. And I remember a patient had a stillbirth, and he just looked at her and he said, well, this effing sucks, and sat down and held her hand, and he was just so good. And I think as a third year, he was the first person I ever felt like was a doctor who I could emulate and be anything like. Mm-hmm. And he kind of saw that I had the maturity to handle it. So I actually delivered my first loss as a medical student, which is really not something that we do very often at all. It was a patient, I was a fourth year, I think. It was a patient who had twins, and one had died in utero, and then she was delivering the healthy and the baby that had died. And I just sat in a chair with her. It's a slow day, and we just talked about life and everything before she delivered.
And she knew she was delivering one who had died and one who had lived. Yeah.
Yeah, she did. And that kind of, was something that I didn't realize was unique, that I had that comfort level, but it kind of continued throughout residency. And I kind of was a person who most people run away from the loss. I kind of felt myself always drifting towards it. Mm-hmm. My personal story is I tried to have a baby in the beginning of my second year and went through a year and a half of infertility. Have come to find out that the way I got pregnant is not recommended anymore because it has a 23% chance of having triplets, which is what I ended up with.
Oh, that was a twist.
Yeah.
Was it like you were on a medicated cycle or something?
I was on gonadotropins with an IUI. So no IVF, just pure stimulation. And I was actually on half the starting dose because the first cycle I went too quickly and robustly. So half the starting usual dose got me triplets, and a retrospective study found out that I probably had about a 25% chance of that happening.
Oh my God.
I mean,
Yeah.
as someone who was just on an ass ton of gonadotropins for an IVF cycle, like you must have had like 10 follicles or whatever. And it's just like, I'm surprised you didn't have quadruplets.
I think I probably did have them, and I think one bowed out kind of thing, because
But you were still you were still in residency when this happened?
I was. So I was a third year resident when I found out. And so I carried, my triplet pregnancy through my third year of residency. At that point, having delivered numerous loss, and kind of had to face down stillbirth, the entire time. And I even got in the shower every morning and told my babies what I wanted them to do, and told them to stay inside and all those kind of things. And I managed to actually make it to 35 weeks.
Wow.
And they're now almost 16, and having that high risk pregnancy and feeling all those emotions, I think I already had. People ask me if that's why I really enjoy helping people through loss, but I don't think it's because I faced down that pregnancy. I think that niche was there, but I do think I am very empathetic to the anxiety that pregnancy can cause because of it. And I think it did kind of shape me. So
this is interesting. I didn't assume you had had a loss, but I am surprised to hear that you didn't, because this is such a focus clearly for you. You're an advocate in this space. And I
had assumed you had it.
And because of the content and the advocacy work, the way you relate to patients is so it's the kind of understanding that you typically don't see from people who haven't experienced it themselves. So it's interesting to me that you haven't had a loss yourself, but I actually kind of am loving this perspective also.
Yeah, I think it's funny. People are surprised, and then I think they actually are more like, wow, where'd you come from kind of thing. And I don't know where I got the skill with this. I don't really, it's not that, I came from a place of having parents who were grief counselors or anything, but I kind of always did my thing. And when I became an attending, I continued to really just do things that I really thought everybody was doing. I really truly thought everybody, when their patients lost a baby, called them constantly and supported them through the next pregnancy the way I did. And I really didn't realize it was unusual until I delivered the baby after a loss for one of my patients. And she said to me, well, now you're going to go teach the Heather way. And I remember being like, what does that mean? And she was like, you don't really realize that nobody does what you do. And I really didn't at that point. They asked me, this was in 2019, to go to the Star Legacy Summit, which was in Minnesota. And I looked it up. I'd never heard of it. And I really, when I went to on that plane to Minnesota, I really thought I was going to meet all these physicians or midwives who felt the same way I did, who I was going to meet my people, and they were going to be like, yeah, this is what we do. And we were going to feed off of each other. And I was going to come home with all these ideas. And I actually was just shocked at how few physicians were there, especially not directly from Minnesota, directly associated. And I think that kind of furthered my wow, this may be me kind of thing. And it's been wonderful. I never in a million years would have imagined that I'd be sitting and talking to you guys. I always thought I'd be a private practice physician, and that was all I'd ever be. I never intended on this, but it became so clear so quickly that nobody else was stepping into this role. And I don't mean that to be egotistical or facetious. I mean, there are people who I met people along the way in the last few years who were like, oh, I'm going to help. And then they just kind of fall by the wayside. And it's been an honor, but I really would love somebody else to jump in, and especially with more position of power, to really get some change to happen too.
And the one thing that really struck me as you were speaking is you seem to encounter this a lot. And I remember asking my OB, who is, not 22, she's probably in her 50s, how common stillbirth is, or I remember asking her when I was pregnant with my subsequent daughter, how anxious should I be? And she was like, it hasn't happened for a really long time. I can only think of a few cases, and she's seen thousands of patients, but you're making it seem a little more common than maybe I had anticipated. So can you just speak to how frequently are you seeing these things? Were you just in a high risk area?
Yeah, I don't think it's a high risk area. New York State's one of the worst states. So we're like 36th or 37th in the country in terms of our rate of stillbirth. So during residency, you take care of so many, and it is not rare. It's about 1 in 160 pregnancies will end in stillbirth, so not rare at all. I don't know why.
And that doesn't count TFMR, right? Or does it?
It would if it was after 20 weeks.
Okay.
Yeah. So in the United States, it's 20 weeks and later. In the UK and Australia and a couple other countries, I think it's 28 weeks. So I have delivered numerous pre-viable babies as well. And when I say taken care of, it doesn't necessarily mean that I actually was the one who delivered them, but there's some weird thing, and my partners will talk about it too, that every patient in our practice, like it seems like who has an anomaly, they're assigned to me. They just happen to be.
It just seems like you're seeing so many of them. I didn't realize.
Yeah, and knock on my woody head, some of the changes we made from our practice in the last 4 years, I feel like I'm hoping I'm making impact on the actual frequency of it. But as I said, I think I ran to these situations. I think I want to say that I do. I gravitate to them. And I want to say that maybe the doctors think they haven't done this much because there's a dissociation from it. It's so traumatizing and so hard. And I think there's just something that cognitively makes you think you haven't seen as much as you have.
Yeah. I would love for you to talk a little bit about way other OBs approach it, because the way you talk about it is the way I would want to be treated as a patient who's having a stillbirth. But our DMs and the internet and everything has told me that most people do not get the care of a physician who treats stillbirth the way that you do. So tell me about what a typical OB's care might be like in a stillbirth situation.
Yeah. I think just speaking in more generalized kind of terms, I think it is separate grieving. I think, and the studies show that the vast majority of OBGYNs and family medicine doctors and midwives grieve a stillbirth. They feel it greatly. It impacts their mental health for a long time, but they're doing that separately. They're also there's no formal education. So a OBGYN resident does not get formal education in grief and death and dying. And so you're only as lucky as the mentor you got. I
can imagine it's like there's one lesson on, like, maybe you get like a paragraph at the end of a delivery thing that's like, and the stillbirth, it's the same except the baby's dead.
Yeah, but I wish that was what it was, because I think if people treated people who have a stillborn baby the way they treat people who are greeting a live baby, we actually would improve care. Right. So I almost wish it was that. I almost wish that people knew that what people really need is to make memories and to have their doctor ask to hold their baby or take pictures with their baby or comment on their baby's features, just, spend time with them, to follow up with them. Like, I think the typical OB kind of delivers the baby, gives her condolences, and then kind of distance themselves. And I think some of that is there is a huge hot seat you have to sit in as a provider when one of your patients experiences this. I have been in that hot seat where the person is throwing questions at me a mile a minute, and some of them are very pointed. They are very direct. They are, did you or your partners do something that led to this to happen? And that's hard. I was actually talking to one of my lost moms today about how we reflected on one of her losses, and that I got in the hot seat with her and I said, let me think through your care. Let's talk about what could we have done differently? What could have been missed? And at the end of it, we both realized that there was nothing we could have done differently, but we went through that together. And she heard me say, I'm going to talk to this doctor. Let me talk to this pathologist. Let me see if they think I missed anything. And that being in the grief space with patients, especially when they're your patients, you have to be a little bit ready to answer to your own care. And unfortunately, we have a society where saying you're sorry this happened makes people think you're admitting some kind of guilt, and that showing your human side is actually the wrong thing as a doctor, when I think showing your human side is the right thing. And that saying to somebody, that but that's not how a lot of doctors are not taught. That is not how a lot of older doctors act. So this idea of, gosh, I'm so sorry about how this happened. And here's the things I'm running through my head. Here's the things that I'm wondering, okay, did I miss something here? No, I did A, B, and C. I kind of tell them how I thought through those things when it was me taking care of them. Obviously, it's harder if it's not you directly taking care of the patient at that time, because you want to not get into that space. But if it is something where I was the one caring for somebody and that happened, the first thing I do is think about what could I have done differently. And instead of keeping that secretive, I actually vocalize it to them.
Well, and I can imagine that's comforting, because I'm sure the mother's doing that too. Like, I noticed that they had stopped kicking, but I just thought XYZ. And to hear that the doctor's also kind of assessing that and coming to the conclusion that there was nothing to have done, I can imagine is comforting. And honestly, even if you come to the conclusion that there was something that could have been done differently, I think it's worse when you just kind of sweep it. Although I can imagine that's also hard from a malpractice standpoint. How does that factor in?
Well, and the interesting thing with malpractice is it really shows that bedside manner makes a difference. And it's not why you should do anything, but I think the separate grieving, I think the saying these things just happen, they're not preventable, especially in this day and age where I get a lot of parents who've lost babies who transfer to us and to me for care, and they know more about it than anybody else. Like,
I am so glad you said that, Dr. Florescue, because I find myself to be a mini OBGYN, and I'm like so in it, and I feel like they like laugh at me. They're like, Judith, why are you like doing this? I don't get the impression that they're taking my research seriously. Maybe it is, or maybe it's not. But like, this is something I really care about. I've had my own experiences now, and it's like, I'm not coming to the table with nothing. I'm coming to the table with ideas I want to try, with options I want to explore, with concerns that I have. Like, I feel like it's my responsibility as a patient to do that. Maybe it is, maybe it isn't. But if I'm going to ask you to treat my anxiety like real, as if it's a real condition, then I feel like I have to do my part too, and like be an aware patient and someone who's like fully invested. It's not fair to leave that all on one person. It's my responsibility to notice patterns. It's my responsibility to just like act in a way that's healthy. Maybe I'm wrong, I don't know, but that's definitely how I see it. I feel like we're partners in this, me and my doctor, but maybe I don't know. I take my healthcare really seriously.
I think a good doctor should always want that partnership. And unfortunately, I think some physicians get very insulted and I will tell you, there's a part that I totally am on that page, is there's no other area of medicine where people try to do our job like obstetrics and gynecology. There's no, people don't make ACL birth plans, let me tell my orthopedist, this is how you're going to fix my knee. And it is a partnership, and it works best when it is that way. And it does take some negotiation. I'll tell you, really the only time in my career where I've struggled a lot was during COVID. And my husband's an ICU doctor, and he saved somebody's life early on in the pandemic, and then got COVID himself and ended up in the ICU. And really, for the first time in my entire career, I wasn't as non-judgmental as I really pride myself in being. And it really just hit so close to home when people didn't want my advice and didn't hear what I had to say about it.
I'm just thinking, like, on this topic, I think, us as SIDS parents, we look at people who maybe don't follow safe sleep practices or whatever, right? And I actually think Judith and I overall are fairly not judgmental, because our sons were in a safe sleep environment and they died anyway. But so I do think that's a thing. I'm wondering, I know a lot of stillbirth parents will see people who choose riskier birth practices and feel
1,000%.
That's a great question.
Alarm or like angry that their babies live. And so I'm wondering how it feels as the provider when you are so intimately acquainted with stillbirth to, deliver babies in maybe less than safe conditions, or parents refusing treatment that they need, or et cetera, something like that.
I think I find it amazing how much control parents with stillbirth have. I've called out with a couple of them, people who are posting about playing the dead baby card, that kind of stuff.
Yeah.
I think there are some physicians who forcefully try to get people to do what they want them to do, but I really want to hope that's the minority. And I think it is very, believe me, I'm somebody who actually, I think, practice in a very midwifery-like way. I work really closely with the doulas, and I'm very open to ways of talking about things and doing things. And I do think there's birth trauma, and I do think there's fear, but I don't think the people who use that phrase, like we're using the dead baby cards, have ever held a dead baby. And I would like to hear happily from anybody who thinks that we're fear mongering when we say we want you to be induced because we're worried about your risk of stillbirth, which is why we recommend most inductions, by the way, is, you know, a lot of the recommended ones are. I'd love to hear if they've truly held a baby who has died in their arms, because
I hear it a lot. I hear it a lot from my friends who, even now, I have a friend who's like, well, I want to try and get as, you know, as far as I can. I don't want to be induced. I don't want to be induced. I don't want to be induced. And I find it triggering for me because where I sit, it's like, but you want a live baby, but you want a live baby. You're taking for granted that you're assuming you're having a live baby. And I'm sitting here from the seat where I'm assuming from my experiences that you won't. So it's like, to me, I get really triggered when I hear people say.
And I remember in my pregnancy that went smoothly. My delivery was smooth. He was born alive. Everything was great until he was 3 months and 27 days old. I remember they were saying, you know, we're going to have to induce you by this date if you don't go into labor naturally. I wound up going into labor naturally, but I remember there was no like, or you could have a stillbirth. It was just like, we're going to have to induce you. And I just feel like, why aren't we acknowledging that that's why we're doing that? It's not just because doctors like really want you to deliver on a Tuesday or something. Like, why don't we talk about this?
I think it's a hard subject for many, and I'm careful even choosing my words when I talk about it. But what I will do if I truly want to induce somebody who I'm really worried that their baby, I use a lot the gas tank analogy. And I say to them, you know, every pregnancy has a different gas tank and has a different amount of gas left in it. And I have concerns that your baby's running out of steam. They're running out of that gas. And I explain reasons why. I find 99.9% of people, if you sit and you explain why you're thinking what you're thinking, it doesn't come off as fear mongering. It doesn't come off as aggressive. But unfortunately, you get enough pushback as a doctor, you're going to put up a guard, and you're just going to get sick of having to explain why you would do things. You know, I always talk to my patients about the fact that 100% of physicians, you know, get themselves delivered between 39 to 40 weeks. And the reason why they're doing that is they know it will prevent stillbirths. It will prevent shoulder dystocias. It prevents NICU admissions. And, you know, and I hope that hearing that this is what we do for ourselves is in some way reassuring, but I don't find for people that it even is. And I think just explaining why chronic hypertension needs to be induced, why diabetes needs to be induced, and saying that these placentas don't work as well. And what might be 41 weeks for a healthy placenta, maybe 38 or 39 weeks for you. And, you know, when that gas runs out, we don't know that the outcome is going to be the same. And, you know, once a baby's struggling in utero, it's not clear that they're going to be healthy when they're born either. So I want to get them out when they still have that stamina to, you know, make it through the birth process. So.
Yeah. Really interesting. I find that just hearing you talk from your perspective, I find it like really healing to me. I don't know why I thought that. I know my doctors always cared. Of course they care, but I find it really healing for someone to like really jump all in and care so deeply. And I just really appreciate that you see us, you know, as people who maybe need an extra hand to hold, or just like a little bit more care and conversation, because I think a lot of people are just a little numb to it, numb to pain. So that feels really validating to me.
Well, and I think that numbness might be the reason why some OBs will say, oh, we don't see this very often. And I think you don't realize the scope of the thing, versus for me, where every single baby I have ever delivered, I can tell you their name and their story. And that's because they just have such a profound effect on my life. But they're also friends, not friends, but they're my closest patients to this day. So I can tell you their stories. I can, and that's because I live it and I feel it and I let myself feel it with them. So, I think there's our brains can protect us from trauma, and I think it is traumatic. And I think that's why I'm really fighting hard for education to be a standard, because I want future doctors to not run away from this grief, but learn how to nestle in it and learn appropriate pregnancy after loss care. And because there's never a doubt in any day that I make a difference in people's lives, even before all this. And I want future physicians to have that. And I don't know somebody seeing 40 patients a day, just doing a pap smear and sending somebody on their way, can say that they know that they made a difference. And when you take care of lost families, even, patients who've lost infants, when you're there for them and you support them, you make a bond that is just irreplaceable. And I want that to be something that I can make a legacy. But I feel like when I talk to you guys, I don't feel like I'm on a soapbox, but when I talk to residents, I feel like I need to get the soapbox on and stand on it. So
tell us about your work. You said you work with residents. So are you like, you've taken this on as kind of like a special project, or you do this as part of your work?
So I feel like it's been evolving a lot. I think once my patient pointed out that this wasn't standard, from her talking to other lost moms, we started teaching. So before the pandemic, we probably taught 12 times, and we taught doulas, we taught PA students, nurses, whoever would have us, basically. And then the pandemic happened, and because I bring my lost moms with me, I really didn't want Zoom, because I didn't really want people to tell their stories and know what most doctors are at typical Zoom things where they're half paying attention. That would have driven me nuts. So we took a break for COVID, and then we probably taught 3 or 4 times in the last 6 months. And I start by just letting them tell their stories, and then we answer whoever's group's questions about, so if I'm talking to a resident group, it's about how to give the bad news, how to support through there. My favorite phrase is what feels wrong is right, and what feels right is wrong. Kind of when you said, it's like delivering a live baby, but they've died, and giving them all that kind of coaching. If it's more with the doulas, it's a lot of about like the patient empowerment message, teaching about importance of fetal movement, and that kind of stuff.
I think that there's some like mixed messaging about, well, I don't know if there's mixed messaging or if there's like patriarchal messaging that's going into women's brains for like generations and centuries, and that's the problem. But I definitely feel like we don't, as the patient, you don't want to be like a bother. You don't know what actually is a real problem and what isn't a real problem. It feels like in your pregnancy, you're asking 25 billion questions anyway. And it's hard to know. I think it's hard to have the courage to like even go in, know it, and what if you're wrong? What if everything's fine?
To say like, I feel like I'm in labor maybe, but like maybe not, or like,
maybe
my baby's
like,
kicking maybe a little bit less. Oh no, wait, he's fine.
Whatever it is, I just feel like it's scary, and I don't think it's as intuitive as it's not so intuitive. Like to say call when there's a problem, like it's confusing, and you don't want to be a bother. And so I feel like there's a lot of education for like the women's side about how to know what is a good time to call, or when you should be calling in and when you shouldn't be. Like what actually.
Sorry. When should women call? When should people call? I think it's actually a great question for you to answer.
Yeah. So I think here's multiple problems with when it comes to fetal movement. So one of the things I do a lot in our practice is I actually say you're never bothering us multiple times when I see every patient in the office, and say you're never bothering us, trust your instincts, that kind of thing, which can get around that a little. And I hope our patients feel like they are never a bother. When I give the education, so the first thing is, I always talk about this, that patients know pretty far and wide that they should not change the litter boxes, even though the chance of anything happening is really small. They know that they should be careful with cold cuts, even though the chance of losing your baby to stillbirth is 990 times more common than losing your baby to listeria. And it's why we feel comfortable telling our patients that a sandwich could do you in, but we don't feel like we can talk about that a baby that's not moving needs to be evaluated. And there's too many myths out there. So, there's too many myths that babies are sleeping or they're running out of room and all that kind of stuff. So I think what's really required, and I think the problem is, I think people, physicians, midwives, PAs, whoever it is, they think that patients know that their babies should be moving and that if they're not moving, they should call. And that just simply isn't true. They are hearing all the things about baby sleeping. They're hearing the running out of the room. They're hearing all these myths, and they're not getting education that we think is so logical because we're physicians or we're midwives. I can't tell you how many patients I took care of during my residency who, when we diagnosed them with a stillbirth, they actually didn't come in for fetal movement concerns. They came in for a headache, or their water broke, or they thought they were in labor. And when we said to them, when did you last feel your baby move? They almost seemed unsure. And I honestly thought it was denial. I thought when somebody came in like that, they really just didn't, they just couldn't face knowing it. But in reality, it was a complete shock.
Okay, we're going to stop there for now. We are going to continue this conversation next week, though, and next week is a juicy one. We talk all about caring for patients after they've experienced a pregnancy loss. She also gets into some detail around the ways that she cares for patients who are actively experiencing a stillbirth or a TFMR. It's a really wonderful conversation. We are so grateful to Dr. Florescue for coming on the podcast. You can find her information linked in the description if you want to chat with her. She's very responsive on Instagram. And we will see you next week for more with Heather. Bye.
To all of our wonderful new friends, we want to hear from you. Email us at aslongasimlivingpodcast@gmail.com and follow us on Instagram at aslongasimlivingpodcast. We'll get back to you as soon as our grieving brains allow.
Yay!